Hello everyone. Hope you have practiced hard and is now ready for the next part. In this part, we'll discuss a very important subject, the port entry. This particular step has often been compared with the takeoff of an aircraft, always with extreme caution. The procedure begins with putting the scope inside the inflated peritoneal cavity, a process called pneumoperitoneum or colloquially pneumo. This is followed by primary port entry. There are several methods and modification of port placement, with each claiming the best result. For now, we shall confine our discussion to the easier and most practiced one, that is intra-umbilical varus entry from pneumoperitoneum. Other popular methods like open port entry, Palmer's point entry will be discussed later in the series. The varus needle has a sharp outer sleeve and a blunt inner one with a spring-loaded action. In intra-umbilical varus entry, a small nick is made at the deepest part of the umbilicus, and the varus needle is held in pen-holding grip and is pushed through at right angle after pulling up the infra-umbilical skin and subcutaneous fat with left hand, providing stability and counterforce. The first resistance will be from the fascial layer, causing the inner sleeve to move up. Once the fascial layer is penetrated, the inner sleeve will move back, causing a soft click. Now, as the needle tip reaches and tends the peritoneum, the inner sleeve will again move up. Once you are through the peritoneum, the inner sleeve will move back, creating another soft click. You are now inside the peritoneal cavity. In our real practice, we reconfirm by two methods that we are inside the peritoneal cavity. One by the syringe test. 5 milliliter water is pushed through the needle to find any resistance. The last drop of water is drawn in by the negative pressure inside the peritoneal cavity. The second one is by connecting the insufflator cable and checking the actual intra-abdominal pressure, which should be either in single digit or even in negative, because the actual intra-abdominal pressure is negative. Now there is significant risk of injuring the abdominal wall vessel while putting the trocar. Now, quick recap of the anterior abdominal wall anatomy seems very apt at this juncture. We are basically dealing with two sets of vessel. One runs along the rectus and the other along the inguinal ligament. The epigastrix along the rectus, the circumflex iliac along the inguinal ligament. Now the deeper vessels, the inferior epigastric and the deep circumflex iliacs are branches of the external iliac, whereas the superficial ones are branches of the femoral artery. The most relevant vessels are schematically shown here. The intra-umbilical incision is extended to the edge to allow the 10 mm trocar to be introduced. The subumbilical pad of fat is being held firmly with left index and thumb and lifted to provide stability and counterforce. The trocar is firmly held against the palm of the hand like a screwdriver, and the sharp triangular tip of the trocar pierces the fascia and peritoneum when thrust into the peritoneal cavity. The index pointing downwards, regulating the entry. Several variations of the entry techniques are practiced, but this being the simplest one. The primary port is through the umbilicus. The telescope may be 10 mm, sometimes it may be 5 mm as well. But all secondary ports are of 5 mm dimensions. The safe locations are these. A central infra-umbilical port is sometimes also used. Now, transillumination from the inside camera light against the intended area is very helpful in avoiding injury to the smaller unnamed vessels. Please remember that the secondary ports are always placed under direct vision. Now once you place the secondary ports, this is the picture from the inside. The direction of the trocar is very important. It should be directed towards the uterus. A misdirected trocar like this can cause severe damage. A quick description of the laparoscopic trolley is very relevant now. You can see the monitor, the camera, light source, insufflator, power generator, UPS and gas cylinder with carbon dioxide. We call it the hardware. The instrument trolley has all hand instruments and different types of cables to connect the telescope and the insufflator and other things. The vaginal trolley. The must have hand instruments are listed here. Some selective exclusive instruments are needed for some specific gynecological lap surgery like laparoscopic shearer, injection needle, vaginal manipulator, harmonic scalpel, oscillator, etc. etc. We'll talk about those during those operations. Instrument sterilization process has changed considerably over the years. ETO or ethylene trioxide sterilization is the most favored now. Autoclave has its place too. Liquid sterilizing agents are especially used for optical instruments like telescope, whereas the camera head and light cables are covered with disposable sterilized cover during the surgery. There has been enormous development in the field of anesthesia in modern medicine, and the mere presence of a good anesthesiologist at the head end of the patient is truly reassuring. It soothes one's nerves and creates a sense of safety. Special care is taken to manage bowel distension and gastric dilatation. Challenging factors such as awkward position, for example, extreme head-low positioning, raised intra-abdominal pressure on the diaphragm, and prolonged exposure to carbon dioxide make the anesthesiologist's job particularly demanding. Preoperative preparation of a patient for laparoscopic procedure is largely similar to those in an abdominal surgery. Overnight liquid diet and stool softener usually suffice. Home medicine like antihypertensives, thyroxine, etc. are continued till morning of surgery. Needle per mouth is advised for 6 hours before surgery. Taking a consent should always be completed seriously following standard protocol. Special consent for possible organ removal must be included wherever indicated. Standard preoperative protocol for surgery is followed and OT discipline is maintained. The position of the patient in gynae lap is somewhat unique. She is put in a modified lithotomy position with hips flexed at 10 to 15 degrees and thighs abducted at 90 degrees. For primary trocar entry, table should always be horizontal. To place the secondary trocars, the table is tilted with anti-Tendelbach position. Maximum 20-degree head low with consent from the anesthetist is allowed. The surgical team position is shown here. With the anesthetist at the head end, the primary surgeon stands on the left, assistant surgeon opposite him and another at the vaginal end. The scrub nurse stands next to the primary surgeon. A designated camera person often stands between the anesthetist and the primary surgeon, especially in surgeries requiring longer time. The monitor is placed at the foot end of the patient in line with the right thigh, 5 to 6 feet away from the surgeon and the first assistant, always at eye level. The second monitor, as shown here, if available, makes life a lot easier for the assistants. The umbilical area is infiltrated with local anesthetic to minimize requirement of postoperative analgesics. A small nick is made at the center of the umbilicus. The maximum pressure is set at 15 to 20 and the flow at 5. The Veress needle is held with the right hand in a pen holding grip and smartly pushed in at a right angle against the counterforce created by your left hand, pulling up the infraumbilical pad of fat. 2 soft clicks are heard and the needle slip moves back. Further testing is done by syringe. Last drop of saline will be drawn in when in correct position. The insufflator cable is now attached to the needle and is switched on. Intra-abdominal pressure would be in low digit, even in minus range, to confirm proper placement. Here it is 1. Insufflation should be done very slowly, allowing 2 to 3 minutes. Monitor is being watched and recording is being done. Total gas entry for the standard abdomen is between 4 to 5 liters. Once that is achieved, the needle is taken out and the intraumbilical incision is enlarged to let the 10 mm trocar with cannula now it's being held against the palm and the index finger will point downwards, guiding the length of the entry. The table position should always be horizontal for primary port entry. The optics are connected, telescope is being put in, and the abdominal conditions are assessed. Now for the secondary trocars, the table position is changed, ideal site is found out, and a small incision is made after injecting local anesthetic. These ports are mostly 5 mm ports. For standard gynecological surgery, we place 2 side ports or secondary ports on the left and 1 on the right for the assistant. Now all these ports are always placed after transillumination and under abrasion. Now once the ports are placed, you are ready for the surgery. The intraumbilical port of entry has few advantages. Like there is no subcutaneous fat or rectus sheath at the umbilical area and is the thinnest part of the abdomen, and the vertical incision at this level gives the best cosmetic result. Disadvantages are when there are periumbilical adhesions in cases of postoperative or in certain disorders, intraumbilical port entry may be a little difficult. Alternative suggestions are going through the Palmer's point, which we'll talk about later. Now, certain safety drills are to be maintained. The Veress needle needs to be checked for blockage and valve operation before surgery. One has to follow the standard operative protocols for confirmed entry, as we talked about, like syringe test and insufflation meter test. And the insufflation should be very slow over a period of time of at least 2 to 3 minutes. The skin incision should be adequate for smooth trocar entry, and all secondary ports must be put after transillumination and under direct vision. Be innovative in trocar numbers and placement as the situation demands. Now that you are inside the peritoneal cavity, we can go for a quick recap of female pelvic anatomy and the restoration of it, which is adhesiolisis, in my next part. It's true that the learning curve is long, but I assure you, your reach is longer. Have a good time.